this is actually a fairly sort of pragmatic sort of clinical talk, I guess, which hopefully sort of feeds into some of the things we've been talking about. The top title up there is the one I realised last night that Jan had given me. The second part is really more what I'm talking about. I was told a long time ago that you can basically introduce about one fact every 5 minutes of a talk. So there are the three things I want to talk about. So if we run out of time, you know what you've missed out on. Hopefully we'll come back to those. So I think most of us know that kinetics are really, really hard, and it's interesting when you're dealing with people who haven't thought about this sort of material that they really don't seem to understand how poor their mental models of whatever is going on are. And certainly I find the more I look, the more I understands the wrong word, get my head around what's going on, the more complicated it all is, and so I need more and more help. I've talked briefly about morphine, which is an example of something really complicated. A simple model, it's got a long time to a peak effect. You get about 80% of the way within about 10 minutes, but it's a drug which then becomes very, very hard to do any sort of thing, any practical titration with. And of course, that's only half the story, because the more you look at morphine, the far more complicated and the more interactions and so forth there are. So we've seen a big swing towards using fentanyl for a whole lot of reasons. It's slightly more predictable. I think what I'm going to put to you is that although remifentanil is a great drug, actively using the fentanyl washout to provide early post-operative analgesia is a good way to go. But it's a drug too that gets complex quite quickly, depending on multiple doses or the timing of the dose, and so forth. And how did I get interested in fentanyl levels and so forth in the first place? So we need to step back slightly. I've had an interest for a while in applying the principles of effect site approaches to volatile anaesthetics. And as part of this, we've been doing some studies using Wakeup, the point at which people wake up from anaesthesia, as an endpoint we can look at. And we've been studying this with our homegrown system and more latterly collecting data on patients with GE Navigator. And here are roughly the results, and there are a couple of things about that. One is that the two systems give very similar endpoints, which is quite nice. It says, they might not both be right, but at least what they're measuring is very similar, come at it from different perspectives. But the question then arises is there an effect on opioids on these sorts of things? We've been hearing about the interactions of opioids and hypnotics when it comes to not just stimulus, but the question is there an opioid effect in our results, and in particular explaining the variability? Short answer is no, but I'll show you why. This paper's from 2003 now, and essentially the conclusion that comes out of it, which was of interest to me, is that as long as your fentanyl level is less than about 4 nanograms per mil, there's no demonstrable effect on awakening. So what that meant was, for these various studies we were doing, we needed to be able to calculate effect site fentanyls. So we did. There's the distribution over on the left-hand side, and in fact we're seeing the median value is about 0.75, and they're well away from that 4 nanogram per mil threshold. And in fact, when we do the statistics, there is no specific effect on fentanyl on distribution. So how do we achieve this? Fortunately, years ago, I was able to get Charles Minto to produce this for me. You've got to use your friends. I have no idea really what's going on deep inside there. Michelle probably does, but for as far as the rest of us are concerned, it's a tool I can use. These days, we've got lots more choices. There's GE Navigator, there's Smart Pilot View. There are also various apps around. The one on, I can't remember what the one on the bottom right's called, but it's from Thomas Schneider. And these are great. You can use these both in real time, even though they say not for clinical use, they're useful for guiding therapy in real time, or for teaching or for demonstration. And the spreadsheet's great if you've got some sort of series of drug doses and a time sequence that you want to analyse offline. So we have these tools. Just briefly, both SmartPilot, which we've heard a reasonable about this morning, but Navigator takes a similar sort of approach but displays the data in a different way. But the particular things I want to talk about, as well as the interactions, is they allow a form of manual target control. So if you know what drugs you're giving and the time sequence, you can use the forward prediction capabilities of the systems to see where you're going to go. Effect site becomes the norm, which to this audience, seems an obvious thing, but I suspect to the other 95% of the anaesthetic population, that's almost a heretical sort of statement. But we start to get modelling for drugs that are not in the TCI toolset, and fentanyl, other opioids are the ones of particular interest. You get the interactions, which we've heard about, and as I say, the predictions and trends are the important bit. So this is actually an example of manual control of propofol. You can see across the top, or maybe you can't, the rates of propofol infusion being adjusted to keep the propofol effect site concentration roughly constant, and it's the yellow line across that middle band. The black line above is showing the interaction effect on hypnosis. The bottom panel shows the antinociception score, if you like. And you can use these tools to guide boluses and infusions. Some of you have seen this before. Here you've got a longish case based on TCI. You can see the purple line across the middle is the remifentanil. We've introduced some fentanyl, which is the pale blue oscillating along, and across the bottom is the rocuronium. And after a few hours of giving these boluses at fairly regular sort of intervals, it gets a bit boring, so the simplest thing to do is simply to set up an infusion, and then you don't have to do anything else, and the concentrations just stay where you want them to be. You can see it took a little bit of titration to get the relaxant about right, and you don't want to overdo that. What do fentanyl levels mean? I've alluded to that a little bit, but to come back to remifentanil, some people still think in terms of mics per kilo per minute rather than concentration. So I say that 1 mic per kilo per minute is about 2 to 3 nanograms per mil as a concentration. The potencies about 0.8. Again, pragmatically, you can actually say they're close enough to be the same. And various people have suggested that a fentanyl level of about 1 to 1.5 nanograms per mil is about where you want to land up at the end of surgery. And these are just a couple of graphs showing what happens if you give a standard 100 mic, bolus to a standard sort of person, and you get above 1. You peak at about 1.25, and you're above 1 nanogram per mil for 7 or 8 minutes. And if you use the sort of way I might have dealt with a simple laparoscopy before I had all these sorts of tools, where you might give 150 mics at the start and then a couple of boluses of 100 mics along the way, this is the sort of profile of both plasma and effect site that you get. And there's that tail that I was talking about before. All right. So if we're using 1 to 2 as a target when you get to the PACU, and we know there's no effect on Wakeup less than 4, again, there's just more data to support that. This is the distribution of data that we saw. Here are some two things on the left. There's some spaghetti plots from a whole bunch of patients in the PACU, and you can see that that's where they're running. So this is not intraoperative now, this is in the PACU, and the doses are being titrated by the nurses to clinical endpoints. Down on the left, are some PCAs running for more than 24 hours. We were just interested we collected this for another purpose. The data is very spiky because actually what we've done is put the hourly data is lumped, but it actually makes very little difference to the shape of the envelope. But the point I'd like to make is that you essentially see an individual has quite a sort of you can see where each person, if you like, wants to be. So it's doable. You can use these things in real time, and you can do it with simple apps and what have you. In fact, it's becoming a common practice. We don't see the Navigator being used as frequently and as well as I would like, but people are often using it to calculate the fentanyl, as a separate tool to calculate the fentanyl levels. And you can see what happens. We go back a few years, we were looking at fentanyl levels during major surgery. What's interesting there is that the dosing at the levels of intubation ranged between 1/4 and 4 nanograms per mil, so 16-fold. There's one character there in a pale sort of greenish, which was had the lowest concentration at intubation, and yet peaked at something approaching 7 nanograms per mil and went to PACU at about 2. Go figure. And there are the means, the intra-op, PACU arrival and PACU discharge means on the right. Laparoscopic surgery, you see a similar pattern. I guess you could create an argument that there's more variability in the stimulus if you want to excuse what's going on, but actually we're getting a far more consistent pattern. There was this expression of alpine anesthesia going around a few years ago, and are these examples? Of course, the next step, if you want to smoothen all of this out, is to say, well, you could use an infusion. There was this assertion that fentanyl's not suitable for long duration infusions, which some people take to mean it's not suitable for infusion at all. I just remind you of the advantages of infusion techniques in general. They provide better control, you reduce the drug dose, and patients wake up quickly. And in fact, that summarises some of the advantages of volatile anaesthesia because it's essentially a form of infusion. And of course, once you give a bolus, you're stuck with it. You've got to wait for whatever natural processes are going on to take it away. But doesn't fentanyl have lousy, context-sensitive decrement times? Well, yes, sort of. Here's one lot. This is another set of data showing what the context-sensitive decrement times from a constant effect site, which is slightly more reasonable, rational than simply on a fixed infusion. But remember, this data goes out to 10 hours, and we're not often talking about those sorts of lengths of time. And in fact, if you're back at the 1 to 2 hour level, you get a 30% reduction over about 15 to 30 minutes. And in fact, this is quite a useful sort of change in the early part of the recovery period. But of course, you'd get it wrong. And although 10 years ago I'd quite like to have seen fentanyl in TCI systems, I can now see that actually people who don't understand, it would be a very dangerous tool in the wrong hands. Just another sort of extreme example of infusion anaesthesia. This was about sort of 6 hours into a 10-hour case, and you can see two things. One is that everything's being infused, and the other is there's a syringe change in there somewhere, but there's nothing else to be done. So it seems to me a very powerful tool. But of course, setting up infusions are complicated, so I've entitled this pseudo-infusion. I find my boluses are often getting smaller. And, instead of giving one big bolus and leaving it, you're giving sort of multiple small boluses to keep the same, to keep and maintain the sort of level you want to be. And I'm doing that not only with, we're seeing that not only with fentanyl, but also with relaxants as we look more at both the relaxant kinetics and where more use of quantitative monitoring. Opioid substitution, of course, is another useful tool of these devices, and if you say at a first approximation that remifentanil and fentanyl are equipotent, that allows you to simply add the numbers to get a rough indication of where you're at. This is actually off-pump cardiac surgery. There's the REMI being pushed up around induction, there's sternotomy, and then once the nasty things are out of the way, you can start to introduce some fentanyl both in the background and also as a way of starting to load the patient for post-operatively. You start to get a feel for how much the patient needs. We've heard a lot this morning that all of these predictions are probabilistic, and in fact we're essentially titrating to effect, so it's a question of defining where the individual patient is on that spectrum, and hopefully the sorts of tools again will help us get there, but we're not quite there yet. So you can make the context sense of decrement times your friend, and you can see that the propofol drops off much faster than the fentanyl does. There we go. Good. All right. So patients vary a lot. We've heard that. This is just an example I found when I was going through. This was a patient in his mid-20s having his jaw wired, and you can see that everything's sort of off the scale in terms of how much he needed around the induction. You try and back off a bit, and the entropy, which is being showed here, starts to get worryingly high, so you've got to turn everything back up again, and here we are with about 4 mics of propofol and a combined opioid of something in the sort of 7 or 8 for someone having, just having a few plates put in their jaw. Yeah, okay. So the next part of this, or one of the other parts of the interest in this, was about predicting the opioid requirements in PACU, and again we've had some sort of allusions to that already. This came out in the last couple of days, which sort of fits into the theme here. They're using response to cannulation and to a bolus of propofol as a noxious stimulus to essentially calibrate the patient. And so if you have pain with either of those stimulus, then you're more likely to have pain. You have higher opioid requirements in PACU, which is interesting. This is an abstract that was presented at the ASA in, I think, about 2004, and it hasn't been published, and my understanding is they have no intention of publishing it. Presumably the resident has moved on and the data is just sitting there. But it was a standard operation. Isoflurane titrate to a fixed BIS and fentanyl administered to a hemodynamic endpoint. And then they calculated the mean intraoperative fentanyl and the fentanyl at first request for analgesia. And they found a good correlation. Now, I found this quite an interesting piece of work. And now, it's a standard operation, so that's a bit different. And it suggests to me that we can actually, by looking, as long as we're titrating the response, we can get a pretty good feel for what the patient might need down the track. So the data I showed you before with intra and post-op fentanyl profiles was around testing this hypothesis. I called it in the wild with a broad mix of patients, and certainly in our first look, we found a reasonable correlation. The suggestion would be you could get about half the analgesia you need intraoperatively, and then it's easy to add a little bit on top. There are actually some issues with using mean doses. I just wonder how much coupling there's gone on. We've started looking at the levels when they arrive. I think discharge analgesia is probably a better marker than the average or the amount they arrive with. We also looked at the relationship with how much patients needed in the ward, and again there is a correlation which you might expect, and a thing we haven't tested out is whether we can actually identify a group of patients who are not tripping the normal acute pain service triggers, but who maybe we should be bringing to the acute pain services attention, because these are people who are going to need much higher doses of analgesia, the sort of doses that the nurses are going to say, oh no, you can't have that because you can only get this much every 4 hours. Again, total dose is meaningless with fentanyl. There's no correlation between intra-op PACU doses or what have you. So individual patients having a procedure tend to simple band. This was an interesting Here's our group of minor operations from the first study, and what was interesting was the student who was collecting this data, essentially those two patients are misclassified, but they stand out quite nicely. They fitted the definition we'd given them for minor surgery, but one was for body surface surgery, but one was a radical neck dissection and the other was a mastectomy. Didn't know. Anyway, you can see what happens. It's interesting looking at what happens with both of them. I think that they arrive in the PACU, they're obviously a bit sleepy, and then they reach a point where they're sort of awake enough to be sore. And then you can see both of them being titrated up quite significantly up to an endpoint. And then they get left alone for 15 to 20 minutes, and their level drops again, and then they get titrated back up to exactly where they were. So this suggests again, and we've heard this before, that individual patients have a point where they'd like to be. We've got these tools we've been talking about, which means we can do this sort of stuff in the theatre quite easily, but what we don't have is a simple way, without using fancy research tools or what have you, to provide the PACU nurses with this sort of information. And of course the catches, you've got to include the intraoperative dosing and the dose timing into the setup. Different groups of patients have different analgesic needs. That's not surprising, but it's interesting to be able to quantify it. We're also seeing interesting changes in practice over time. We're seeing closer matching of the intraoperative and the PACU fentanyl levels. I think some of that may be increasing awareness and increasing use of some of these tools. We're also seeing changes from year to year, and I think some of that represents changing anaesthetic practice, more use of multimodal analgesics and the like, but also I think, and particularly with laparoscopic surgery, we're seeing big changes in surgical techniques and in the training of their trainees and what have you. This was just a group we looked at the simple bone procedures. We know they're a problem that we don't deal with particularly well, and they have pain. Again, we've seen quite a dramatic. Well, there's two things there. One is that there is fentanyl levels were actually higher when these patients left than when they arrived in the PACU, which suggests we were significantly underdosing them intraoperatively. And we've also seen a slight drop between over a 1 year period, which I like to think means that we're managing their pain better, but I can't prove that. So the PKPD stuff is complicated. I think displaying effect site information can really help you understand what's going on, but it also, I believe these things are very powerful management tools. They also are providing us with insights into how our practice is changing, and as I say, we need a simple tool to provide effect site opioid levels in the recovery area. Thank you very much.